go ahead and get started. I'm sure people will trick away. So today is case conference series. So Andrew asked me to come and present an interesting case. And this is, I promise there will eventually be some bleeding involved in the case, not to give anything too fancy away. So I'm hoping that by the end of this, we'll be able to kind of talk about some of the common library tests that we will learn and how the pattern of testing can help us work up some of the bleeding patterns. I have no conflicts of interest yet. And this patient, some people in the room, you might know this patient. It may become clear to you. Some of the people might have already know. Yeah. We'll start with some timeline. I'll have a couple of kind of stops along the way to talk about the case and talk about some of the key findings and remind us of some things that we probably learned long ago. And if you're like me, have definitely forgotten several times. I had to relearn again. So the patient was, we're going to do in real time. So you're called to see a patient in the ED, or your team is admitting. He's a 78-year-old. He's got insulin-dependent diabetes. He had a history of cabbage about 20 years ago that was uncomplicated. And he's brought up by EMS for acute onset of facial swelling and difficulty breathing. The backstory is he woke up this morning, with some new URI symptoms of cold, and he took some remedies. There flew the low clot extract, which is a Chinese herb, a Chinese plant along with almond extract. And he took some citron tea. And he went to take a shower, and then several hours later, all of a sudden his face started blowing up, and he couldn't breathe, so we called an ambulance. On arrival to the hospital, the team in the ED noted that he had significant stridor, he was in respiratory distress, breathing very quickly, labored. He was intubated emergently for respiratory distress as well as airway protection. And the provider documented that he had a lot of perioral tongue, tubular, laryngeal edema. And on intubation, they also noted that he had some pooled, clotted blood in his posterior aorta. I don't know why this is going in random order. I'll just put it all up. That was not intentional. So to round out his history a little bit, as I said, he had the diabetes. He actually is on insulin. Oh, yeah, sorry, it says it right there. He's on insulin. He had a cabbage, and he also has hypertension. He, family history-wise, actually, his mother and father lived through a very old age with no known medical problems until their very old age. He's got 2 children who are healthy. He immigrated from China 25 years ago. No major important social history. He lives with his grown children and his wife here in the city. These are his medications. He's on aspirin. He's on amlodipine for the high blood pressure, insulin and metformin, and he takes a statin as well. So we just stop there for a second. So far, any kind of diagnosis he's running through your mind. So this guy suddenly is fine. This is fine. And 2 hours later, he's got this kind of rapid onset of facial swelling and difficulty breathing. Not that uncommon, but what do you guys? For quick differential. No ACE inhibitor. What are you going for there, Master? Angioedema, yeah. Sounds a lot like angioedema. Anything else on the differential you have for this guy? Pretty. Yeah, there's not much really, right? So just to kind of maybe take a quick pause here. This kind of smells like a duck and quacks like a duck, but just to kind of think a little bit, what are the features that make this angioedema as opposed to something else? Rapid onset, absolutely. Anything else? Swelling, rapid onset swelling. What about the location? Fairly classic location. So this is angioedema. It's usually onset over after a trigger, or not, if the case may be, but usually comes on with over minutes or hours, and then starts to subside either over hours or days, as opposed to lots of other forms of edema that are kind of a little bit more insidious, both with onset and improvement. Angioedema happens to be often in the face, can also happen in the skin and the bowels, and importantly, it's not gravity dependent. Um, so that's angioedema. Just thinking about etiology as we go through the case, it'll be interesting to see if we can link back the angioedema to some of the other things that happened. And this is bringing me back to med school, but anyone, it's up on the board, but the two kind of main categories of angioedema are the bradykinin mediated and mast cell mediated, and what might you ask the patient to help differentiate the two pathologies? Anyone who can read? Or anyone who can't read but just knows off the top of their head. So bradykinin mediated it's a different pathway. It's not kind of IgE mediated, so they're not going to have the mast cell symptoms. They're not going to have pruritus or hives, and the mast cell mediated will. So just some common things that can cause angioedema. That's very beautifully brought up an ACE inhibitor, which is all comers the most common thing, and especially for bradykinin mediated angioedema, that's going to be the family feud. That's going to be like top of the list. You get 90 points for that. One other thing to note: so deficiencies of the C1 inhibitor can also cause angioedema. That can either be hereditary or acquired. That's mediates the breakdown of time in a process that I couldn't possibly begin to explain to you, or I want to even try. Mast cell mediated is usually environmental triggers, so things like drugs, insect bites, dust, pollen, and specifically NSAIDs can actually trigger a mast cell mediated angioedema. Anyone ever seen that? I've never seen that before. But there's a section that I'm up to date about it, which just reminds me how amazing up to date is. Okay, so I mean that's already interesting, and now we go through the case, and some other things start to crop up that we'll focus on. We'll zero in on. So you go to examine him. His vitals are up there. Nothing dramatic. He's on the kind of borderline tachycardic, not febrile. He's vented, but his gap thing actually seems to be pretty reasonable. Just some focus parts of the exam. So on HE and T exam, he still has the pool of blood in his oropharynx that's kind of clotted a decent volume. That was noted initially on intubation. And his skin, you note that he has diffuse ecchymosis in his bilateral arms and legs, and also on his neck where he closes his collar. He has a bruise there. There are kind of different stages of healing, and his wife is kind of at the bedside, so yeah, these are strange. I don't know what to make of it, but it's happened over the past 3 months that he's had those. And then you're rounding on him with your team, and you notice that the Foley that they put in for some reason in the ED is just packed full of blood clots. And the resident told you, yeah, as soon as they put the Foley in, there was some clear urine, and then a few minutes later, there just started to be copious blood, and urology's on the way to do some CPI. Nothing else major in the exam. Oh, there is. I don't know why it's popping up separately. I blame Andrew for his PowerPoint template that he sent me. But he's comfortable hearing it eventually. Of course, you can notice. So you do some basic labs, and you note that he's got a white count. His renal function electrolytes look pretty normal. His LFTs are essentially normal. His lactate's okay. He's a little bit anemic, but that's not too dissimilar from his plot from about a year ago. And his APT is 61.9. So you're a little bit curious about the blood and the Foley and the bruising, which is like has been going on for 3 months. His PTT is a little bit high. So you ran out some of the review systems, which you just documented as point negative in your note. But you go back to kind of suss out a little bit more. So the bruising has been happening over the past 3 months. Over that same time, he's kind of been progressively fatigued, which is a new symptom for him. No weight loss. And then he didn't have any other episodes of bleeding prior to this admission. So no nosebleeds, no hematuria, no floating urine, no bloody bowel movements, and no joint pain, no stiffness, and no itching, no allergic symptoms with this angioedema. So it doesn't seem to be an mast cell mediated process. No other rashes. Anything else you guys want to know before we move on to maybe how we would think about this guy?
Any disorders in the family?
Good. So we all know about his mother and father who lived to a ripe old age with no problems, no bleeding disorders. And I'm blanking, but one of his parents had surgery that was uncomplicated. I forget what surgery. Anything else?
Is he up to date with like malignancy screening?
Good question. So he had, I think his colonoscopy had been about 12 years ago, but was negative. Do you remember? He had, he was slightly overdue for colonoscopy. He had not had PSA screening. Yeah.
Has there been any workup for this anemia or anything needed for a long time?
He'd been, his hemoglobin had been like in the 11s on a visit that I think we had got from another hospital. I don't remember having any records of what was up there, but the family didn't know anything was up. So this was the first time that he had interfaced with our hospital, and I don't remember that we had I think we had looked and not found an old PTT.
That PTT is on mission.
That PTT was on arrival to the hospital, yeah. Presumably he had one 20 years ago when they did the surgery, but we just had it, we couldn't find that. Any other thoughts or questions? So, what are we kind of worried about what we're dealing with here? Maybe just like a very brief differential for, this guy's got bleeding from multiple sites, he's got some bruising, his PTT is elevated. Yeah, so clotting factor deficiency inhibitor. So some kind of new bleeding diagnosis. And actually, you want to walk through why you zeroed in on
Well, let's see. It looked like his PT was elevated, so that sounds like it's the intrinsic pathway, which would be not factor 7, but basically all the other ones besides the pathway. So like 8 would be the one that we have in the university. That's what I was thinking.
So that's exactly right, but it takes me about 4 more hours to get there than like this did for us. So maybe let's walk through that thought process a little bit, and I'm going to lean on you when I make a mistake and explain this poorly. So this is something that just, no matter how many times I learn, it doesn't really stick in my mind. So we can try to work through this together and review review the tests and decide what we're going to do. So I think Mike really zeroed in on this being a bleeding diagnosis, a clotting factor problem might be high in the differential. Anything else that you guys would want to worry about? Go through it, but anything else so far that we have a differential, or is that definitely what this is?
Could have like a platelet disorder. That can cause upsetting.
Yeah, I love it. So that's a pretty good differential, and we'll go through some of the testing. Sorry. Oh yeah. So it's kind of the summary of the important information that we had initially. So his platelet count was normal. We hadn't done any functional assays of his platelets, but I think we would consider a functional platelet problem, such as von Willebrand's. He was on aspirin, although this is kind of way out of proportion to what we usually see on aspirin. His sarmatime was normal. His PT-INR was normal, and his APTT was abnormal. So it's probably helpful to back up and just try to remind ourselves what each of these tests are. So I put this on the board. So Mike did a very good job of summarizing for us what these two are looking at. So the PTT, this is kind of a simplification of our clotting cascade. And a clotting cascade kind of ends in this common final pathway, which is a requirement for clotting as the endpoint for both of the PTT and PT-INR. And that's, factors 1, 2, 5, and 10. So 1 being fibrinogen, 2 being thrombin, as well as 5 and 10. So a disorder of those clotting factors, if it's significant, will result in abnormalities of both testing. And then PTT is primarily a test of the intrinsic pathway in addition to the common final pathway, and PT-INR of the extrinsic pathway. So with PT-INR being normal, we're starting to think about some kind of disorder along this side of the clotting cascade, or a platelet problem. What can we say? Any thoughts on what we can say about the thrombin plant being normal? So what is the thrombin test? What is thrombin plant? Good. I'm glad that nobody else knows. In case you make me feel stupid, I had to look it up. But thrombin time is really a measure of the kind of the very end stage of the clotting cascade. So it's basically a measure of your fibrinogen activity. So do you have enough fibrinogen, and is it getting converted adequately to your fibrin clot? I believe that's correct. Anyone want to correct me on that one? Probably not the most elegant way to describe it. Anything that kind of affects your fibrinogen level, so things like DIC, should affect your thrombin time. So thrombin time is normal, and fibrinogen is also normal. Okay, so I think the most helpful way to go about this then, for new bleeding diathesis, is look at the pattern of the test that you get, and try to understand how that feeds forward into what the likely diagnosis would be. So we go through these individually, and again, the smart people in the room, like Dr. Fisher, will correct me when I go astray. So the first scenario is if your PT is prolonged and your APTT is normal, what kind of etiology do you start to think about? There's some on the board, just to kind of reason through it. So if your PTT is prolonged and your PTT is normal, well, you could have some issue with the common funnel pathway that's preferentially affecting your PT rather than your APTT. So you're going to be really thinking about a problem with the extrinsic pathway, primarily factor 7. So that could obviously be factor 7 deficiency or an acquired inhibitor of factor 7. And actually early liver disease, for reasons that are slightly complicated, mild vitamin disease, primarily affect factor 7 versus some of the other factors. That's kind of a hand-waving explanation for that. Coumadin, as we know. Is that, any questions on that? Thoughts, pontifications? Okay, so yes, you have a prolonged PT and a normal APTT. What if you have, so if both are prolonged, we can go to this one next. That really could be almost anything. And it affects the common final pathway. So these factors, certainly DIC, so fibrinogen at the end of that pathway will cause deficits in both PT and APTT, as well as severe vitamin K deficiency and severe liver dysfunction. Affects factors that are in multiple parts of the cascade, including so that's not our patient, though. Our patient had a normal PT and an abnormal APTT. So we're trying to figure out if there's something wrong with his intrinsic clotting cascade or something else that's not measured by this test. So that would be deficiencies of these factors that we talked about, 8, 9, 11, or 12, and von Willebrand disease. So I think you mentioned von Willebrand disease. So what was your, I guess maybe, how should I phrase this? So how would von Willebrand disease cause a prolonged APTT? Is maybe, I guess, what I'm thinking question. Right? Or it's a random thing that I read on Up to Date and I want to share with you. Question, but it turns out, I guess, there could be like moderate or 8 in patients with von Willebrand disease. So von Willebrand patients can have a pattern of either normal PTT, of a normal PT and an abnormal APTT, or they can have normal coagulation tests. That makes sense. I go through that. Okay. All right. So I think we zeroed in on a pretty good, and then lupus anticoagulant can give this pattern of coagulation testing, but the phenotype is drastically different. So this is a bleeder, not a patient with a venous problems. So we kind of zeroed in on probably one of these factors or von Willebrand disease. Can we kind of clinically decide which of those is more likely? Does it sound like von Willebrand disease? If so, why? And if not, why not? Or maybe a narrow question. What would argue against this reason? Yeah. Yeah, it's almost always a genetic lifelong condition, right? If you said massive surgery got to this age of his life without a bleeding problem, it's very unlikely to be von Willebrand disease. So I think we could probably clinically rule it out if we didn't go down the pathway. He actually was at another hospital initially, but they didn't go down the pathway of testing for von Willebrand disease. I think that was reasonable given his history. But it does really seem that with this pattern of testing in this history that we could zero in on one of these factor abnormalities. So the next thing that we did, or they did, was to send these studies, and this was the result. So 9, 11, and 12 were normal, and factor 8 was, it's a functional assay, so the activity was 1%. So the coagulation studies, they work.
Yeah.
And this is what we got. So I guess what would the next step? I gave you a little subliminal message there. Or maybe Hershey, you walk through. So you gave us a couple possibilities for initially for why you might have a bleeding gap. So you want to walk us through a little bit more what you're thinking, maybe, and now lead toward what you're doing next.
So I think you're talking about getting a mixing study.
Yeah.
And the idea is if he's got an inhibitor, then when we mix his blood with normal blood, the inhibitor is still going to be there as the inhibit normal blood. So correct? I'm thinking I think correctly.
Yeah. So and then you said that you can have like a kind of congenital or an acquired disorder of one of these factors. So congenitally, usually it's an absence of the factor.
And then if you add normal blood, you're giving them the factor.
Yeah, and it turns out you only need a fraction of your factors to actually clot properly. So if you give 50% of someone else's serum and add it to your serum, even if you have no factor at all, you should completely correct. Whereas if you have the other possibility, which is you have an acquired problem, that's usually an antibody or an inhibitor of your factor, which is still present, even if you put more factor in there, that new factor will get inhibited. Okay, I see some nodding heads, so I almost lost you like I lost myself trying to figure out these things. So the mixing study will help that. Out of curiosity, who thinks that this guy's going to correct with mixing? Who thinks this is a problem of efficiency of inhibitor? And who thinks this is an acquired problem? Right, because it is the same reason for his not von Willebrand disease. Von Willebrand disease, he's lived his entire life without a bleeding problem. He's had major surgery. He's had no family history. So this seems much more like an acquired problem. So lo and behold, this is the result of his mixing study. So the way this is comes up in the chart. So they'll repeat the baseline PTT, which is very similar to what we had initially, and then so they'll mix it with a 1-to-1 solution of stock blood from someone. I don't know how they get that, but it's like a lab-specific reference. And so immediately they mix it, it actually corrected, but it turns out that some of these inhibitors take time. They need to be incubated over about an hour. And lo and behold, if you wait an hour for this guy, it gives enough time for that inhibitor to work, and the PTT uncorrects. Doesn't go back up fully to where he was, but it really should completely correct on, as we said, on giving normal blood. So the fact that it's abnormal in any way makes this a positive or negative study. Okay, so we kind of talked about that. And we were highly suspicious that there was an inhibitor, so it was actually a test you could use that inhibitor. His was positive. I won't go into the details, but it was kind of a low titer, but still positive. The hematologist had to it was explaining why that was interesting, which I won't go into now. I'll tell you a little about his clinical course, and then we can kind of maybe wrap it up with some information about acquired hemophilia, which this guy had, and maybe try to fit it back together with his initial presentation if possible. So we started on recombinant factor 8. He still was in the hospital, I think, and you took care of him for even longer. He had complications from ongoing bleeding for a long time, requiring multiple infusions of factor 8. He was on CPI for his hematuria for a long time. Eventually, I think that his hematuria resolved, the Foley came out, and he was discharged on recombinant factor 8. Anything else major that happened for him?
Steroids, right?
Oh, sorry, yeah. I was going to get to treatment at the end, but so it's an immune-mediated pathology that the antibody acquired inhibitor. So he was started on steroids and Rituxan as well as recombinant factor, and eventually improved. So our final diagnosis was angioedema, and then he was found to have an acquired factor 8 deficiency, acquired hemophilia. I'll talk a little bit about acquired hemophilia, and then we can try to tie it together. So it's super rare. This is like one, this is could be a case write-up for some of the students actually. This is something that happens 1 in a million case years. Factor VIII is the most, if it's going to happen, it's the most common disorder to have an acquired hemophilia from. It is a medical emergency, so a large portion of patients present with serious bleeding, and actually 20% of patients die as their index of diagnosis or index presentation from this disease. So it's one of those things that's super rare and also super deadly. It's a very reassuring combination of characteristics. So it's very useful to talk about it. So when we see one eventually here, not something again, we won't miss it. Etiologies are interesting. So there was one study of prospectively of 500 patients. These are the most common identified etiologies. It's usually autoimmune disease. Actually, postpartum was up there. Obviously not an issue for our patient. Malignancy, autoimmune disease, and then drug induced. And these are the drugs that are published as having been associated with acquired hemophilia. There was no data on this extract that he took, the low blood extract that was published, so it's reasonable to think about. And then, so he came with angioedema that was diagnosed with acquired factor VIII deficiency, which is kind of this a bit strange, right? He had one slightly rare condition and then was diagnosed with another. So we were trying to figure out if we could tie them together in any way. Any thoughts on whether that would be possible?
His hospital wasn't angioedema at all, and it was just like a hematoma, like a neck hematoma.
Yeah, we thought about that. He'd had scanning, and I mean, there was no like frank collection of fluid. It just seemed more to be kind of interstitial. But that's very reasonable that this was actually not angioedema in the first place, so misdiagnosis.
Had it been on antibiotics?
Yes, he had URI. He woke up that morning. I just took some over-the-counter remedies, and then like 2 hours later, it was angioedema. So he might have gotten antibiotics at the other hospital, but that was after his bruising had already started and after the angioedema. So I think it was part of both of those.
Not related at all. That the angioedema could have been related to some of the herbal medication that he's that he took his URI symptoms before, and perhaps there's another reason to explain this factor VIII.
Yeah. So I mean, always want the simplest explanation, right? It turns out a lot of these acquired hemophilias are diagnosed some of them present with just spontaneous bleeding, and some present for another when they access the health system for another reason, right? So they come in for surgery and they bleed for a long time after surgery and diagnosed with acquired hemophilia. Maybe he just had angioedema and came in and was found to have all this bleeding because we're putting tubes down his throat and tubes in his bladder and would cause a lot of bleeding. The other thing we thought about was if he had an acquired inhibitor of one part of his blood, could he have an acquired inhibitor of something else? And you actually can have acquired inhibitors of C1 cause angioedema intestinal. We're super excited. So I think that's in the end that was the diagnosis that was made. So this was a kind of idiopathic acquired hemophilia that was randomly not randomly found because he came for angioedema that would find him doing this blood extract or some other ingestion that he had. He was worked up for malignancy. It was PET scan. He had flow cytometry to look for hematologic malignancy. It was negative. Rheumatology saw him. They were very unimpressed for any rheumatologic signs or symptoms. He had a basic kind of serum workup for autoimmune disease, which was all negative, and he was not postpartum. Questions? Yeah.
We already talked a little bit about the treatment. So the idea of giving recombinant factor that you just like overcome the inhibitor, if you super saturate the
I think we go with maybe.
right, because some of that factor should be.
Yeah. So this is all coming back now. So the mainstay treatment, which I didn't have a slide on, which is why I probably skipped over talking about it, is, as Andy mentioned, the immunomodulating immunosuppressive therapy to treat the actual production of the inhibitor. And then the recombinant factor, I think it's a different structure than the actual native factor. So I think the thought was that this inhibitor doesn't actually inhibit the recombinant factor.
But his response to the recombinant factor was really slow and sluggish and incomplete. But he didn't really respond until the cup.
Was there a thought that the inhibitor was actually inhibiting the receptor? Yeah. It's obviously complicated, and we should invite any colleagues. What other thoughts? Yeah.
I had, we had submitted a case to SHM for a poster a few years ago because we had someone who had a new diagnosis of some kind of hematological malignancy and also basically fell on a bus and, had major intracranial surgery before, but fell on a bus and basically had massive bleeding everywhere and had retroperitoneal bleeding and also worked up to have, factory inhibitor. And I think a few months ago, we had another patient that had incidental finding of pancreatic cancer. Also during the pre-op, the PPT persistently was elevated, which were elevated for a long time, but until pre-op, that's when we actually paid attention to it. And turned out it was had it also.
Yeah, it's a good. Take a message to pay attention to clinic studies, but sometimes we gloss over it.
Yeah, I think
you can have an abnormal test, which can be a sign of an indolent, unpresented disease that wants to look up, although they're rare. And was the malignancy thought to be the trigger for your?
There's no other.
There are a portion of these that are idiopathic, and that's probably what this failed. Unless you develop some malignancy, this could be kind of early.
I have a question for the group. I mean, when you first presented the case and there was blood in the pharynx and then there was blood with the Foley and then there was all different stages of bruising, the question really that you try to answer is, would I have worked up the coagulopathy then if the cards were normal? Because the cards came back with a PPT of 60, I guess. So obviously you have to pursue it. It's trying to put things together. But how long do you say, well, this is just Foley trauma, Foley trauma, Foley trauma? And he bled for quite a while. Do you do that on day 1 or day 7, right? And you go back and think, well, maybe this was an angioedema. This, you scan the neck, which I guess it was. But you can get coagulopathies with a normal coax too. Like fibrinogen issues, there's fibrolytic pathway problems, so it's possible.
Bleeding to that degree, it warrants discussion with hematology.
Yeah, I think so too. I mean, day 1, people might have some Foley trauma and other, some non-specific bruising, but if it doesn't really recover properly, you need to reassess. Or the anchoring bias, as they say.
Yeah, I mean, he's not the right age or history for von Willebrand, but he hadn't had surgery. Yes, could in theory be related. Yeah. Or some other point synthetic or point of dysfunction problem.
Yeah,
you wouldn't find on any other testing at all.
Because he takes some herbal medications and a lot of them have, impact liver function.
Absolutely.
Yeah, but a good reminder to consider your coagulopathies.
What is the next? So for von Willebrand, check for von Willebrand, but if you were looking for platelet dysfunction in general,
That's a good question. So the bleeding time is not sensitive or specific, but there's a PFA 100 test, which is a little bit more specificity. My understanding, it's still not very sensitive. If anyone knows any more about PFA test, it's a non-specific test of platelet function. Does anyone use that test? Yeah, I think it's probably not something I would be sending without consultation with a rheumatologist. And I think von Willebrand's is more of a kind of specific workup in the context of the clinical history that's supported. But for other platelet functions, it might be helpful. You had some smart fun.
Whether it's repeated,
that's reasonable, yeah.
For pizza, good idea. I had that happen in pre-op. I had a pizza back in '70, and I remember in hematology to do pre-op. I like
Cured
it.
And the question is, I guess, often, like, do you just repeat it, or do you, like, while they're there, do you repeat it and do a mixing study, sort of at the same time, like, how many times did this patient come back, for, like, these swabs, like, you know, something with just straight TB is, like, sometimes easier, because they'll, like, do the PTT, but they'll do
Especially pre-op when it's like your last Friday.
I know.
Sad you can't see them again.
Yes.
But repeating it would be better.
Repeating it once at least is, or, you know, or if, you know, you have old ones, I mean, it's been on for a while. So.
This question back to the angioedema. What was your final thought about it, and what happened afterwards? He's 78, so.
Yeah, so you had to work up for these other kind of crazy C4, C1 deficiencies, which is negative. He's not on any other medication that is known to do this. He can have idiopathic angioedema, but he did have this new, actually it's the second time he taken blood clot extract. We couldn't find case reports of angioedema from blood clot extract, but there's a similar plant that does actually impact the kinin waving pathway. So there was some thought that maybe that was the diagnosis, but I don't think that was 100%. It seems that temporarily make the most sense. But he took that medicine, and 3 hours later, he had this massive rush. I don't know if you remember anything from allergy. Always a herbal medicine.
That's the problem.
Well, it's such an easy target because no one knows what it is.
But so it was right after he took that he had the reaction.
Yeah. It made sense to me. Like I bought it, but I don't think it's like proven by any means.
Just do it to other kids.
Don't take it again.
Yeah.
For hockey,
Yeah.
Take it again.
We'll do that on 10 Center. All right. Thank you guys.
All right, good job. Thank you.